Greetings, everybody, and thank you to the organisers for giving me the opportunity and the privilege of talking about emergency care for children in Africa. I think it's such an important topic. And what is emergency care? Well, it's part of a continuum. We tend to focus on either critical care or the emergency department, but really it starts at home, goes all the way through how they get to hospital, indeed the emergency department, inpatient care, and finally, how we sort out them going home. I'm going to concentrate on the emergency department because that's where I'm most experienced, but I'm very aware that I'm simply one link, in fact, in the chain of care. Because emergencies can happen anywhere along the way, and we really need to be prepared for them. What are we trying to do in emergency care? Well, our primary goal is to evaluate and manage and treat all the sudden illnesses, the unexpected injuries, but also to try and prevent secondary or indeed primary disease. And it's not always an easy thing because our hospitals tend to be very siloed, vertical care, either for a disease or for a specialty. And yet here we are dealing with everything and often with very little help. But it's really important because we can treat and reduce admissions, which takes the burden off the hospital, takes the burden off the patient. And we can also reduce those lengths of admissions if we get our treatment right. What about access to emergency care? The recommendations are that more than 80% of the population should travel less than 2 hours. And yet when a study was done in 2018, 29% of people travel more than that. And the range was between 25 and 90%. And this is for the whole continent. And if we look at this, all the little red dots are where the public hospitals are. And of course, they're where most of the people are. But nevertheless, there's huge areas where there's very little access to health. And we need to be aware of that and make a part of it as policy so that these children can get help quickly. What about the children in hospital? Well, this is a pilot study that was done from Kenya and with Columbia University, and they were looking at some of the hospitals and simply asking what was going on. And in 67%, they said they had more than one child at the bed, sometimes daily. 83% had bed occupancy anywhere between 63 and actually 120%. 83% was what the average was. Only about half felt they had enough oxygen, and 60% needed more gloves. What they also requested was some standing operating procedures. These are really some tools with which to work. Lab problems, they needed help with record keeping, and then of course the infrastructure. And yet when we look at the population of Africa, it's young and it's growing. And in 2020, less than 18-year-olds made up 630 million children. And if you look at this figure, it shows you that proportionately they're going to grow. And so we need to anticipate that more children will need help. And emergencies will occur everywhere, and they'll consume resources, whether we're doing a good job or not. So we need to consume resources and do a good job. So emergency care can be very different in different parts of the world because we all have a different background, facilities, staff, different illnesses. Our patients may have different expectations, and I don't believe there is a right model. though I do think children should be kept separate from adult distress and the nasty things that may be seen. But we have very few standalone paediatric emergency departments, often mixed with adults. But I don't think it's such a good idea to be mixed with outpatients or with maternal and under fives units, because we're mixing two very different needs and different groups of people. But however we do it, the principles and the goals are the same. So where we work, we're often going to have a lot of patients, little time, little diagnostics, and always that pressure to do something with them. And therefore, to have a good team, to have a good environment, is going to make those decisions and those actions so much better. And if your staff are demoralized, the whole place is crowded, it makes it very difficult to do a good job. So what are we looking for? What do we need? We need staff. Staff is the most important thing. And I'm going to leave that till the end because I think it's so important. Physical structure and equipment, important. We need process, tools to help us. We need coordinators, by which is really meant collaboration. And we need to monitor so that we know what we're doing. Structure. What do we need? We need space. So many emergency departments with a sort of added idea. And yet we need a space in which we can have dedicated areas to work, resus, etc. We can have lighting and we can have privacy when we need it. Here's an example. You can see where the black arrows go. There's a flow of patients. There's an area where people wait. You can see what's going on. There's room to think, room to move. Awareness of the whole structure is very easy. Here it is. We're not all given that though, but we have to try and make do with what we've got and advocate for better space, privacy, because we need to be able to talk and to be able to examine, particularly to the older children. And if you're like this, you may be doing a good job, but you may not be getting the real story of what the problem is. So we need tools. Triage is an obvious one. We need protocols, admission forms. We need some form of infection control, and there's lots of others. And then we need to collaborate across departments and internationally so that we can do the very best given our circumstances. Here are some tools as an example. Obviously, triage on admission. You can have early warning score systems to help monitoring on the ward. It's not all going on in the emergency department. Here are some examples of triage. Depends on what facilities you have as to what you'll use. And here, there's some really good work going on, and the space is not ideal, but put the process in, get things going, and before you know it, you'll be doing a good job. Your hospital administrators will start looking at that and will give you a space that is better. And that's exactly what happened in Ola During. And here they are, and they did a wonderful job by reducing the time that children had to wait to receive treatment. And because of all that, they now have a very nice emergency department. What about monitoring and evaluation? We've got to do it. If we don't look at what we're doing, we're never going to improve. We need to want to improve. We need to think about governance, think about mortality, morbidity, and where we're going, whether we're improving. So what qualities do we need? Well, we need to be safe, effective, efficient, equitable, obviously timely. But I do think there are some softer, less measurable things. And that's empathy, and looking at the whole child, showing our compassion and consideration, and of course being patient and family-centered. So I said staff are important. I put them in red. We need to motivate. They need to be trained. And there's lots of barriers. You can see them there. That if that staff is worn out and there's no teamwork, it's difficult to enthuse, difficult to do a good job. And yes, we need courses, but we've got continuous professional development. We've got on-the-job teaching, and all of this needs leadership. We can use wall charts, job aids to help people, apps, if people are happy with that. We need a staff, they are specialized, you know. We need people who have a broad view. We need people who can task shift, multitask. We really need a leader. We need an emergency pediatrician in charge, and we need nurses who are specially trained. And that requires us to recognize pediatric emergency medicine as a specialist. And I think our role is to advocate for their training and for their position. So key components are good management and leadership, ownership, and advocacy. After all, the emergency department is the hub of the hospital. The decisions made there will influence every other section of the hospital, and indeed who's admitted and who's turned away. So we know what's needed. Let's do it. Let's do it right and do it well, work as a team, and show that we care. Thank you.
Hello, everyone. My name is Charlene Kilba, pediatric intensivist at the Greater Accra Regional Hospital in Ghana. And I'll be speaking about critical care training under the African Pediatric Fellowship Program. The APFP was established in 2007 at the Department of Pediatrics and Child Health of the University of Cape Town in South Africa. The aim was to train doctors, nurses, and allied health professionals in pediatrics and pediatric subspecialties. This was to improve the clinical workforce and increase capacity for research and training across sub-Saharan Africa. APFP works by partnering training institutions and pediatric societies across various countries in Africa. The training institutions identify gaps in training and clinical care and elect candidates who then apply for the APFP fellowship training posts. On admission, the fellows are supported with scholarships that cover their university tuition as well as registration with the relevant professional councils in South Africa. With increasing support, APFP has also been able to support fellows with a stipend for the period of their study. This collaboration ensures that fellows are coming in with the full backing of their institutions and their countries and have a post open for them upon completion of their fellowship training. APFP has grown in the past 10 years and currently is partnering 39 institutions across 17 African countries to build capacity in these centers. This map of Africa shows the countries in blue that have existing partnerships with the APFP and the number of fellows that have been trained from those various countries. So far, about 163 doctors, nurses, and allied health professionals have been trained under the APFP. The Red Cross War Memorial Children's Hospital is one of the best resourced pediatric centers in Africa, and not just infrastructure-wise, but human resource-wise as well. The Pediatric Intensive Care Unit there is a multidisciplinary unit that admits children with both pediatric and surgical emergencies, as well as for elective postoperative care. The hospital runs a very successful pediatric cardiac surgery program. The advantage to training in Red Cross is the similar disease burden across many African countries. Also, as students and at the University of Cape Town, fellows have access to the UCT library, which is an enormous resource for journals and books and articles. The hospital also hosts multiple courses in the year, and fellows have the opportunity to attend these courses. The Pediatric Critical Care Fellowship is a 2-year program. Unlike many other training institutions, experience in a pediatric ICU or an ICU generally is not a prerequisite, because it is understood that most candidates are coming from areas that do not have these facilities. The program, in addition, has some flexibility to include rotations that are not part of the core ICU training, if seen as a need for the candidate. At the end of the 2-year training, fellows submit a dissertation to the University of Cape Town and also take the subspecialty exams with the Colleges of Medicine of South Africa. Since 2011, under the APFB, 6 pediatric intensive care specialists have been trained for 4 countries across Africa. These are Kenya, Ghana, Malawi, and Uganda. The advantage to training under the APFB is the network that fellows are able to join with this program, where we form good bonds, not just with our South African colleagues, but also with other fellows in other specialties from various parts of Africa who are part of the APFB program. And this connection continues even after training. Under the APFB, the mentorship does not end at the end of the training. APFB actually encourages follow-up visits where supervisors visit the fellows when they go back home to see the services they have set up, help them with training needs and ideas as to how to make things better, and just to encourage them in the work they're doing. So these pictures are from a visit in 2019 by the APFB team to Ghana. That is, on the left side is Dr. Shamel Sali, who is the current head of the Pediatric Intensive Care Unit at the Red Cross Children's Hospital. And next to him is Eugene, who would actually be starting his fellowship training this year in Cape Town. What are the challenges? Limited training capacity for the enormous need that Africa faces at the moment. And would need more training institutions to join the partnership program so that more slots are available each year for candidates. Funding is also a great problem because most African countries do not place pediatric intensive care as one of the main priorities. However, COVID has opened our eyes to how much we can do through virtual learning platforms, and the opportunity for pediatric critical care to be supported from outside of Africa is more enormous now than ever. Thank you very much.
Hi, I'm John Adebiapia, a senior specialist, pediatric critical care, the head of pediatric intensive care unit at the Komfo-Anokye Teaching Hospital, Ghana. I'm here to speak on the subject setting up PICU where previously none available. Hopefully at the end of this talk, I'll be able to provide a brief overview of the subject, especially applying to low middle income countries, and that the audience will have a fair idea of what considerations are needed. Also to motivate for establishment of a PICU, describe the processes needed to facilitate PICU establishment, and list some of the potential challenges of establishing a PICU. This is not an exhaustive talk because the time is quite short, so I'll be quite focused. Why is this needed? It is estimated that 6.4 million children under the age of 14 years die annually around the world. More than 90% of the deaths actually occur in low middle and income settings. The leading cause of death and disability are from preventable causes, such as sepsis, pneumonia, trauma, mostly acute pediatric illnesses. Most of those cause disability and death, and these can be prevented with basic emergency and critical care interventions. We should therefore find a way of delivering pediatric critical care and intensive care services, even in the context of low and middle income countries. There should be a justifiable reason why PICU is needed in the context of limited resources. In our case, the data showed that mortality was halved after establishment of an emergency unit, but stagnated for quite a number of years. We therefore looked at the data and identified that patients dying were actually dying due to inadequate critical service, and that was what led us into establishing the unit. The available intensive care services in our hospital, and I'm sure it applies to other low middle income countries, will preferentially provide services to the adult population and leave the pediatric out because of lack of skill. So this leads to the question, what is PICU? PICU is a place in the hospital where patients with critical illness are managed. And these patients are pediatric cases. Depending on what age you peg, we use 14 years as a cutoff, but in some cases we do up to 18 years. This can be achieved through provision of specialized care to patients with severe critical illness or life-threatening conditions. To be effective at this, there is a need to group such patients together in a designated area. And then let me borrow from the World Federation of Societies of Intensive Care and Critical Care Medicine classification of ICU, with modification by Marshall in 2017 and Cyrenin in 2018 respectively, and captures the components as to have a dedicated geographic area where we can provide support for organ dysfunction and failure, which may be mild to complex, provide monitoring and treatment, and should have a dedicated staffing, and also be able to offer research and education. What are the major considerations? One, I think one of the key things is to engage the facility management in the establishment process. This might be initiated by the management or a staff member interested in establishing that facility. Management commitment to support the unit when established is key for the viability of the unit. It will ensure that throughout the duration of the process, the needed resources are provided, such as equipment, funds for training, consumables specifically for pediatrics. Two, then you need to build a team, and a team, PICU, will be specialized, well-trained members. The composition of the team should have a medical component, the nursing component, and allied health, especially biomedical scientists. Let me mention that the nursing and medical should be bona fide PICU members. The others might be incorporated from other units. Recruitment of individuals for the unit must align with facility and staff development. The unit must also team up with other disciplines available in the hospital. Each of the team members are equally important to achieve the objectives of sustainable unit. A team leadership, preferably the team leadership should be a pediatric intensivist, someone who has been trained to take care of. And they are to provide coordination and leadership. Training. Training is key, and that before that is done, an assessment of the unit is needed in order to provide a carefully planned out and then rolled out training processes. And it will require a broader scope and goes beyond the medical and nursing care. Let me suggest that training in basic medical equipment management, I'll refer to that as a handyman sort of a person for both medical and nursing staff. Is critical in low and middle income countries because of lack of staffing to take care of these. This will ensure that these groups will be able to troubleshoot minor equipment malfunction and fix them. You need to have protocols and guidelines to guide what is done at the unit, and that this should be available to all care workers. Following development, team must be familiarize themselves with the guidelines, and as much as possible, a structured in-service training to understand what this is about and the process, how to go about it, so that everybody is on the same wavelength. The other key issue that needs to be considered is quality improvement. And I will suggest that the decision must be taken to incorporate quality of care right from the inception. The process should be put in place to develop quality issues and guidelines, specific items to be monitored. This should be followed up with frequent reviews to assess. The results must be made known to all staff to address recurrent issues so that it doesn't happen again. This will actually test the culture of the unit, and it must be done very carefully. Challenges to expect. A number of mitigating factors is known to stand in the way of establishing a PICU in the low middle income countries, especially in our areas of Saharan Africa. There's lack of pediatric friendly consumables and items and equipment, high attrition rate of healthcare workers because they are needed elsewhere and they will be moved into other areas. So planning must be made ahead to consider or to factor all this. Non-availability of complementary subspecialties as team, part of the team, inadequate financing as most of the services are out-of-pocket payment. Here, there should be, you should explore establishing other means of funding to cater for, to pay for the services provided. Additionally, electricity, medical oxygen, and gas availability can be a headache. And if it's there, it might not be piped. So you need to find a way, innovative way of ensuring that this doesn't become a major problem. And there, the last one I want you to consider will be the naysayers. There are people who will be focused on trying to prevent you from achieving what needs to be achieved. And these will require innovative and tactical approach to address them. In conclusion, let me conclude by saying that setting up a PICU in a low middle income country is feasible, but attention must be paid to the fine details such as challenges which will need careful planning to resolve them. Thank you.
Good morning, everybody. I'd like to speak today about high-tech, low-tech renal replacement therapy. My name is Mignon McCulloch, and I'm based at the Red Cross War Memorial Children's Hospital in Cape Town, where we see quite a lot of acute kidney injury. So just historically, it used to be called acute renal failure. We all now know that it's called AKI, and it's often fluid-related, resulting due to shock or sepsis. We can get it as drug toxicity, and this is often related to aminoglycosides where there's been no monitoring. And the easiest management is often to give some furosemide and hope for the best. The causes that we see are often public health related, such as clean water resulting in diarrhea and vomiting. As we know, there's no easy dialysis, and so it's important to try and prevent this in the first place. When we do get AKI, there have now been many definitions, and the one that we currently like to use is the KDIGO definition, which divides it into two groups. One is looking at your serum creatinine, and the other is the urine output. So urine output is easy because you can measure that specifically over 6 hours, 12 hours, or 24 hours, and then grade it into the staging according to the urine output. Serum creatinine relates to what your baseline is, and that's often a problem because we don't know what the starting creatinine is. But once you've got a baseline creatinine, from there you can actually work out what the creatinine is in relation to 1.5 to 2 times normal, more than 3 times normal, and then you can divide it into stage 1, 2, or 3. We know in neonates specifically there are many risk factors for AKI, such as low birth weights, low APGAR scores, many of the drugs that we use, also mechanical ventilation, and then of course if you're working in a cardiac unit, cardiac surgery itself with bypass, as well as ECMO. So I'm going to leave you with one formula. I'm a nephrologist, and so the GFR, or glomerular filtration rate, is an easy formula to calculate if you have a height and a creatinine. We use an easy K constant of 40, so you can get it in different amounts, but we just use a baseline of 40. And so if you've got a height of a child who's 100, a creatinine that's 100, which many people may think is normal, you end up with a GFR of only 40. So we know that a normal GFR is 80 to 120, and as I like to try and tell people, in an exam you want 100%. And so that's an easy formula to work out according to your length. So prevention is better than cure, and so conservative therapy in the beginning is to try and prevent fluid overload. So we do use furosemide. The study showed that your long-term outcome doesn't make any difference whether you use furosemide or not, but as we all know, it's much easier to manage a child who's got AKI and who's still passing urine. So we tend to use 1 to 2 milligram per kilo per dose. We're not using very large doses of 5 per kilo anymore, and we're not giving it as a quick flush because that can cause deafness. So we try and run it in over about 20 minutes. The other alternative is to use an infusion, and we would start with 0.2 milligram per kilo to a maximum of 1 milligram per kilo per hour as an infusion. But if after 3 or 4 hours there's no response, I would not continue with this because you can just get harm from furosemide and it's not making any difference. Interestingly, HAEMOFILTRATION is making a comeback, and so a single dose or even a 6-hourly dose has been used as a diuretic. And just to remember that once you've got some problems with AKI is to try and avoid your nephrotoxic agents. We also know that from Kath Maitland's FEAST trial, mortality after a fluid bolus in African children, that too much fluid is not a good idea. And the important thing about fluid is to look at your percentage fluid overload. A nice easy formula from Stuart Goldstein: fluid in minus fluid out over your admission weight, and this can be done on a daily basis. And once you get to a fluid overload percentage of more than 10%, it is probably time to think about some renal replacement therapy, definitely if it's over 20%. And so looking at your KDIGO outcomes, the suggestion if you've got AKI is that a continuous form of renal replacement therapy is better than intermittent, much better for hemodynamic stability, and it suggests that you've got higher rates of renal recovery. Why would we need to dialyze somebody? Well, in addition to the fluid overload, you may be running into some potassium problems, and we all know that there's some medical methods which we can use to shift potassium. So 10% calcium gluconate as well as sodium bicarb is very useful. The easiest drugs to find when you're starting off with this is furosemide and salbutamol, because most wards would easily have that available. Oscillator is going out of fashion because there have been reports both in adults and in neonates of colonic perforation and NEC. And then insulin and dextrose we try and move away from because people forget about the dextrose. They don't check the glucose, and before you know it, you've got a child with unrecordable glucose while they're running insulin. So just something to be aware of. Back to basics, important to insert a urinary catheter, as you don't want to be doing renal replacement therapy for somebody who's got a full bladder. Important to get a history of an antenatal scan if it's a neonate. And we now do lots of point-of-care ultrasound. To do a renal ultrasound at the bedside, check your bladder that it's not full and check for hydronephrosis. So absolute indications for continuous renal replacement therapy would be your hyperkalemia. We see very little clinical uremia, but we do see a lot of acidosis and fluid overload. Relative indications for renal replacement therapy, metabolic and liver causes, and very occasionally a hypothermic child who may benefit from warm fluid into the abdomen. So what are the modalities? Well, you need to choose and do what you're best at. So we've said not intermittent, but continuous, and peritoneal dialysis fits into this continuous renal replacement therapy. In infants and young children, PD is preferable, but sometimes that is not possible, and then we've moved to CVVHD. So we are now pushing the boundaries in that as we've got machines that have got smaller filters and we've got smaller lines, we can now do, even in a newborn, we can do both CVVH as well as HEMO. This is a child who had hyperammonemia from a metabolic condition. The biggest challenge is getting a line in, and realistically a 6.5 French is a good size line, but there are now arrow lines which come as a 5 French, as an 18 and a 20 gauge double lumen line, which is also useful for doing dialysis on. So here's a very small child that you can see. The filters and the lines are now neonatal and pediatric friendly. And more recently, the Carpe Diem machine has been introduced for children between 2 and 10 kilograms. This shows the ultrafiltration rates and the priming volumes that you need for this machine. It is specifically geared for small children, and you can use a 4 French double lumen line to do filtration with this. And we have had some experience of kids down to 1.7 kilograms. However, this is difficult. We need to get more experience in this. You need all of these ABC guide, your vascular access, your blood pumps, your dialysis prescription, filters, anticoagulation, and ideally at the end of the day you need people who are comfortable in running these machines. Vascular access is the biggest problem, and in our setting when we started off with this machine we called many friends, many colleagues, and many dialysis technologists. When you do a survey across the world, you actually see that in centers, whether developed or developing, as we now call them, low resourced or high resourced or high income countries, PD is actually available in almost all centers. The gold standard would be to attempt to transfer a child to a pediatric center. Failing this, get the surgeons to place a Tinkoff, and if that's not possible, a bedside PD catheter. We have recently drawn up these PD guidelines for acute kidney injury in January of this year, and you can see 5 of the 7 authors are from Africa. Bedside PD is very practical. You need someone to manage the airway, an empty bladder, sedation and local anesthetic, and then we create artificial ascites by running saline into the abdomen before we insert a pigtail PD catheter. Very important to maintain a sterile technique. So if you can't go to theatre, we bring theatre to the bedside. We use manual dialysis with a fluid warmer, and you can see here is the dialysis bag. You get fluid running into the child and then fluid running out. In many warm countries, you don't even need a fluid warmer, and at present there is a Fresenius acute PD-PED set. But if you don't have that, you can use Buretrols, and you can make up a set yourself using a 3-way tap, provided you do this all in a sterile fashion. This is the drainage bag. This is a little baby who has an adult central line used as a PD catheter. And in many ways we say that this is low tech, but this is a child who's had cardiac surgery, who's got nitric oxide and oscillator, multiple infusions. So this is actually high tech, but using low tech of peritoneal dialysis, and many highly resourced countries would place a PD catheter into any cardiac baby that had surgery. For me, the changes in my practice in Africa has been a 3-way tap and a Buretrol, and with that you can do anything. We've also suggested that you can do your own locally made fluid using Ringer's lactate and adding 50% dextrose to that. For every 10 mils you make 0.5%. So if you wanted a 1.5% dialysis strength, you would add 30 mils to 100 mils of Ringer's lactate. And some people have even used nasogastric tubes as dialysis catheters. Saving Young Lives is an organization that has done teaching about bedside PD. We run a skills workshop at Red Cross. This is the one just before the COVID pandemic. And these people then go back to many countries in Africa where they have challenges of fluid and catheters. And so we did an audit on our own locally produced peritoneal dialysis fluid, and we only had a 4% peritonitis rate. So important to take care that you don't create infections when you place these catheters. Continuous flow peritoneal dialysis is very new work that's happening in pediatrics. You put in 2 catheters and we found that you definitely get better flows. And the future is to give PD a better reputation. If you do get an infection, then you can just treat it in the same way as if you get a pneumonia, you wouldn't remove your ET tube. So in the same way, you can treat through the PD catheter with antibiotics in the bags. We need a steady supply of PD catheters. We are using the Cook catheters, and important to get a sterile. This is work that we're doing just using a pork belly and inserting bedside PD catheters as a practice session. And my take-home message is for AKI, prevent it in the first place. No patient with AKI should die without at least an attempt of a PD catheter using homemade fluid and even improvised catheters. We're suggesting African solutions for African problems, and importantly, you can make a difference wherever you are. To say thank you to my team, both the renal team, our intensive care team, and also the fellows who come with us to train. Thank you very much.
Hi there, my name is Minette Kutsia, and I work with peds crit care nurses and teams throughout the African region. I'm based in Cape Town, in South Africa, at the Red Cross Children's Hospital, as well as at the University of Cape Town. What an excellent lineup of speakers have set the scene of PICU and on this continent. So with the scene set, my brief is to add the perspective of nurses, critical care in our region. Let's start with the numbers. At this point, there's still only 2 schools of nursing that run programs that train PICU nurses in the sub-Saharan region. The University of Cape Town and Gertrude's Children's Institute in Nairobi, Kenya. The Kenyan program has increased its capacity significantly from 2013 when they started, from 8 graduates then, and this in 2019 they graduated 19 nurses. The Cape Town program has been going for a little while longer and has graduated nurses from across the region. But as you can see, far, far too few. Our current data estimates that there are only about 240, maybe 250 trained PICU nurses working in PICUs in the region. And the PICUs are as few. Many countries have only 1, sometimes 2 PICUs, and in most countries there are fewer than 20 PICU beds to a vast population of children. Most of the graduates I describe now work in the first and often still only PICU in their country. But my brief is perspectives of PICU nurses, so let me share some glimpses of how Africa's PICU nurses have come into their own. In this last year, like nurses across the globe, we've had to dig deep into our every resilience. Processes and practices we believed in before, we thought we could trust, have had to change. And 2020 will always be remembered as the year of the COVID-19 pandemic, probably more so than the International Year of the Nurse and Midwife. As I speak to PICU nurses across the region, I hear an uncanny resilience and 2 clear themes: perspectives of best possible place and getting the basics right. What you'll hear throughout is that best possible place is about physiological regulation, not always about being in a PICU. A certified APN and PICU trained Namibian nurse described being called on to set up the first testing station in her nation's capital, and then to commission and run the COVID-19 ICU, where they nursed a 1,010-gram baby with his mother, critically ill, post-cesarean, and with COVID. They discharged them both home 4 weeks later with the infant weighing 1.5 kilos. This care profile was different, she said. It was mother-led care, with staff on the periphery and outside, rather than the mother on the periphery and outside. Her encounter confirmed the protective, fine-tuned autonomic regulation provided by zero separation of a newborn from its mother. A NICU nurse midwife from Sierra Leone describes how the lessons she learned there 4 years ago about getting the basics right and tracking outcomes significantly influenced their outcomes in the critical care in the pandemic in the last year and a half. In Malawi reside another group of courageous PICU nurses worth mention. Chisomo and her team really did have to start from scratch when they commissioned a new surgical PICU, the first PICU in the country. 2 PEDS trained nurses and 20 brand new graduates fresh out of general nursing training to launch a PICU. That was 3 years ago, and now they run a 6-bedded intensive care unit, including PEDS and surgery, and their unit boasts significantly improved outcomes, particularly for newborns who require surgery for congenital conditions. She describes 2020 in this way: we worked a lot with what we have. It means that we worked without international residents, but I think we're doing okay. We're better at working with what we've got, and everyone is doing so well. In the north of South Africa, I had a conversation with an APN in PICU. He's one of only 20 Africa-trained pediatric nurse specialists in the region. He's energetic, and since his appointment in another newly built children's service with a 12-bedded PICU, 8 NICU beds, and an additional high care, 6 beds in addition, he's tracking measurable, sustained patient outcome improvements, particularly through robust engagement with policy and practice norms. In conversation with him, I'm struck by how easily he describes the statistics: bed occupancy and patient stay, staffing norms, salaries, the cost to company. The numbers are at his fingertips. Conversation with him switches easily between the clinical and administrative roles. These could be directing an admission to stabilize a critically ill newborn with gastroschisis, or stopping for a conversation with a distraught mum fretting about a critically ill child, while he's on his way to training, nurses assisting a mother heading home with a child with a tracheostomy in situ. In Africa's pediatric ICU settings, mothers are no different from in other PICU settings in the rest of the world, a recent APN graduate told us a couple of months ago. They're as keen to be involved in direct care. It's not only about decision-making, it's about practice. Another one in her group said, we've got to bring these guidelines home. She was referring to the rigorous process of adapting existing evidence-based practice guidelines to local home contexts. These guidelines are utterly based on well-assessed, recent peer-reviewed publications and reviews, and answer clinical nurses' needs at the bedside in PICU. What's the most important to you in your practice, I asked. She thought a bit and then she said, I think partnering with others, with mothers and families. I'm a nurse because of sick children, really. She's using a very practical day-to-day clinical application of the African ethic called Ubuntu. It denotes a deeply held belief of people in the region, and it means I am because you are, a collective ethic that we're only now starting to describe and celebrate more in the practice of critical care children's nursing. Of course, there are challenges woven through the perspectives of PICU nurses that I interact with, and these include 3 prominent recurring challenges, which are all directly related to the delivery of critical care of children in the region. They're about an inadequate nursing workforce planning, about varied equipment and its maintenance, and practice protocols imported for implementation, as is from the global north. As we build and commission new PICUs, these are key areas that need planning, but rarely reach the decision-making table or the budget. None of the PICU nurses I mentioned return to work in settings with 1-to-1 nurse-patient ratios. In many, the norm is more likely to be 1 RN to 2 or more likely 3 critically ill children. In a number of units, auxiliary nurses with a very limited scope of practice are an accepted norm. At this point, I know of only one country that has a national regulator that accredits PICU nurses. This doesn't help with incentives to train or for hospitals to have an expectation or to raise the budget for employing critical care PEDS trained nurses. This is a very different composition of PICU nursing workforce from the global north. And it's only one of the reasons why practice protocols can't be summarily imported and implemented. In our academic unit, we've been designing and developing best practice guidelines and tools that have all been articulated from work with local units. As we continue to work on a series of tools and local evidence-based practice guidelines with PICU nurses in the region. These have all been published under Creative Commons license, adding to the bank. Planning the nursing workforce in PICU can't be easy for planners or hospital administrators with little articulating the nature and contribution and expectations of PICU nursing work. Articulating objective indicators that allow nursing work to become more visible and measurable is another aspect of our work. And it adds metrics to the toolkit. As you can hear, I have one of the best jobs ever. I get to work with and learn from a group of extraordinary, courageous and resourceful women and men, nurses that work alongside similarly energetic and visionary clinicians with critically ill children across the region. These kids are so sick. Their conditions always complicated by already underlying vulnerabilities and fragility. Their families are so committed, and most have tried to care and access care in ways way beyond their own capacity and resources. My learning has been rich and varied, and I've been humbled time and time again by the warm reception of me or my teams into these teams and their units. Their appreciation of training or thinking that we may bring or add is large. I've also watched them graciously receive what they may not really have needed. I've been in newly built units where donations of equipment are so many and varied that they fill bed spaces. In one unit, I counted 7 different manufacturer brands of monitoring equipment, all requiring different adapters, circuits, and consumables. In another 12-bedded unit, I counted 8 different bed types, all adult beds with different moving parts, some simple lever systems, some requiring electric power sockets to move. I've watched nurses scurry in an emergency to find a different ventilator with a circuit that may fit, or resolutely move another piece of non-functional equipment into a passageway just to make some space. Not because they haven't maintained the equipment well, but because what they have are so often from varied donations. equipment no longer used or considered obsolete in other units, sent in a container when equipment elsewhere is being updated. So I'm taking advantage of this platform and standing on the other side, the side of givers, the resourced that give to the under-resourced. And I'm making a plea for responsible giving. It's a heartfelt plea that comes from a place of having learned to be much more humble and circumspect about advice and giving. Please consider coming by invitation only. Consider giving of your best and giving only what recipients will find utterly useful to the nature of their work in local practice settings. Let me wrap up where I began. Celebrating the perspectives and resourcefulness of PICU nurses in the region. I'm grateful to continue to learn as I listen. And I hear articulation of best practice as intentionally engaged with families, and that recognition of autonomic nervous system regulation in critically ill infants and children, and getting the basics right with metrics. In this 2021 year, we hope we could predict that nobody still can. I celebrate unapologetically African, unapologetically excellent children's nurses, nurses who continue to work to best effect in Africa's health systems.
Good morning, afternoon, or evening, everyone, depending on where you are. Thank you to WIFPICS for this opportunity to present at PIC Awareness Week, Africa Region. I'm Dr. Ilse Appel, a pediatric intensivist, and I, together with Dr. Noor Parker, were the pedi intensivist managing the PICU at Tygerberg Hospital in Cape Town at the start of the pandemic in 2020. South Africa is estimated to have a population of about 59 million. 7 million are within the Western Cape, and within the city of Cape Town, 3.7 million. 25% are not covered by a medical scheme. 1.7 million children are between the ages of 0 to 14 years, with 37% experiencing multidimensional poverty. There's increasing demand for ICU and high care unit dependency beds in the Western Cape and South Africa as a whole. We have a high burden of disease, increased surgical requirements, and increased detection of critically ill children. Within our context of limited resources, it's essential to efficiently utilize the resources we have available. Tygerberg Hospital is a tertiary academic hospital offering health services to the adult and pediatric population. It is affiliated to Stellenbosch University and offers a 4-bedded step-down high care unit with the 10-bedded PICU. The pediatric department consists of 270 beds, offering specialists and subspecialist medical and surgical disciplines, as well as allied disciplines. Since March 2020, South Africa has been in a state of emergency with risk-adjusted lockdown levels in place. We experienced our first wave peak between June-July 2020, and our second wave peaked between December 2020 and January 2021. Tiered communication levels were established between the National Department of Health, National Institute of Communicable Disease, and the provincial government departments. Within the Western Cape Department of Health was enabled to establish effective and efficient communication with hospital managers. And hospitals in turn established COVID operation committees who communicated to various hospital departments and their staff members at Tygerberg Hospital. Infection prevention and control strategies to address suspected or confirmed COVID-19 infection was established. COVID-19 testing, notification, and contact tracing policies were established. The COVID testing strategy evolved and was adapted as the pandemic phase changed. The hospital adapted its visitation policy, ensuring limitations, and also provided permits for caregivers during lockdown curfew periods. We ensured caregiver symptom detection and management, and various occupational health aspects had to be addressed. The hospital was reorganized into COVID-19 high-risk and low-risk areas. Outpatient department was de-escalated, and elective surgical procedures were cancelled during the hard lockdown period. Urgent emergency admissions were prioritized, and teaching and learning was adapted to digital platforms to limited small group meetings and ward rounds. The flow of patients with suspected or confirmed COVID-19 disease was managed. COVID-19 persons under investigations, PUIs, or positive patients were managed accordingly. The definitions of PUI evolved and was adapted as the pandemic progressed. All patients admitted to the PICU were managed as suspected COVID-19 disease. Entry into hospital and transport to wards from referral centers were directed. Ambulance crew members were directed to use specific COVID-19 PUI versus non-COVID lifts. From COVID-19 wards, patients were then decanted to COVID-19 positive or negative wards. It was essential and still remains essential to ensure adequate triage, early recognition, and source control. Early isolation of persons with suspected COVID infection is important, as well as caregiver symptom detection that is ongoing. Standard precautions apply to all patients, as well as empiric additional precautions implemented for suspected cases, such as droplet contact and airborne precautions where applicable. Thoroughfare through high-risk COVID-19 areas was limited, as well as the number of healthcare workers into high-risk areas were limited. Adequate PPE was ensured and monitored, and adequate hand hygiene facilities in all areas was provided. Training in the use of adequate IPC was implemented and reviewed regularly. Protocols were put in place to manage the deceased, starting with confirming the diagnosis and contact tracing, and contact and airborne precautions when handling the body. Administrative controls were implemented through the IPC committee of Tygerberg Hospital. There was a facility readiness checklist, and the committee was assigned responsibility for environmental controls and triaging. Environmental controls in place range from opening windows to ensure airflow direction to protect healthcare workers, patients, and caregivers, to barrier protection between patient beds and in waiting areas. Within high-risk areas, it was also essential to ensure adequate air conditioning. Within the PICU, barrier protection between patient beds were essential. And there was also signage inside and outside high-risk areas to ensure that IPC measures were adhered to. Specialists within critical care across South Africa consulted and collaborated to establish guidelines for the management of critically ill pediatric patients who were suspected or proven to have COVID-19, and these guidelines were distributed nationally. Recognizing the risk and consequences of burnout and fatigue among staff as the pandemic progressed, various support structures were established to provide emotional and psychological workplace support, such as the COVID-19 helpline, online Zoom meetings, enabling peer support, as well as face-to-face small group-based meetings occurred at Tygerberg Hospital. I would like to acknowledge patients and caregivers at Tygerberg Hospital and thank the PICU team for their hard work, care, and dedication to provide quality health care in these challenging times. And I'd like to invite everybody to save the date for 2022 for the WIFPICS, which will be hosted by Cape Town. Thank you.